without further ado, I'm going to introduce our first speaker of the day, who is none other but Tanya Brown Griffith, Programme Director, Director of Population Health and Inequalities and Personalised Care and Race Equality and Prevention Programmes for NHS Sussex. Evidently, from her long title, you can tell that she's a busy woman. So thank you, Tanya, for your time. I'm going to hand over to you now to talk us through a bit of a recap of what was covered last time, but also to give a heads up in anticipation of what we're going to cover today.
Thank you, George. And you're so very kind about my title, but all I do at heart is my values align with improving population health and outcomes. And as a physiotherapist by background, although I'm now in sort of the program director role, I am keen just to improve the health and care of our population. And however we can equip you who've joined us today for this webinar, whether it's around knowledge, skills, capabilities, whether it's sharing case studies, whether it's attending webinars such as this. You know, my real goal is to ensure that we all, as much as possible, do our part in sort of improving our population health outcome for our population across Sussex. So to echo what George has said, welcome to everyone. This is the second webinar in 3 sessions on population health. Really happy that we've got our Population Health Academy up and running, and there's lots of interesting new developments around the Academy to come. So in terms of our 3-part webinars, webinar 1, where we did in November, and yes, you can, if you missed it, you can obviously see the recording. I will make sure we share the link. It's also on the Academy webpage, and we will also share the link to the Academy in the chat. Webinar 2, which is today, we're focusing on the tools for population health, and there will be webinar 3 to come in March, which is about what works. You know, how do we ensure that population health lessons are learned in Sussex? How do we learn from our neighbours in the southeast, but also nationally and globally? To just to refresh our memories and to really just remind us what we covered in the first webinar back in November, I've just popped up on the screen really the focus we had around how all of the work we're doing around the Population Health Academy, what we presented in webinar 1, what we're presenting now in webinar 2 and 3 to come, are focused around how we deliver against our Sussex strategy. And it's really just improving lives together. And if you haven't yet seen the strategy or had a chance to read through the strategy, the summary is on the intranet, on the NHS Sussex intranet. And again, we can drop the link in the chat. As Sussex-wide workforce members, you have access to all the resources that we hold on the intranet as well as the Academy. And just to refresh people's memory, we have 4 aims around our shared delivery plans. And the Academy really fits into the sort of 3rd aim, which is on the continuous improvement. But remember, we also have national programs around health inequalities, the Core 20+5, the Levelling Up, so many levers to enable us to really address inequalities where we identify inequalities, or even just to start to identify them in the first place and take positive actions going forward. Now, individually, you may not be able to do much on your own, but that's why we're here to connect you with our public health teams, with our BI teams, with colleagues from across the system who are doing various interesting and really excellent pieces of work, working with our inclusion health groups, also working in areas that we haven't yet been doing quite a lot of work in, working with, for example, asylum, refugee-seeking communities, working with our Gypsy Roma traveling communities, and working in at a very small level in non-English speaking communities, and really showing some positive changes. So really, as a reminder, really what we focused on in the webinar was an introduction to health inequalities in November. We focused on what health inequalities was at a national level, where we had inequalities in Sussex, or very educational and sort of very expert colleagues from public health really took us through where our main inequalities lie in Sussex, where the global burden of disease lies, and some of the meaningful actions that we can take to really address those inequalities and improve population health. And remember, when Sir Marmot produced the Levelling Up report, he said that it's small steps that lead us to that bigger change. And if we improve health and care for the communities that are most excluded, the whole population health improves. The access to services improves. Those who require it the most will access emergency services, and therefore the blockage, the challenge, the operational pressures we have will ease. But it does require all our concerted effort and for us to keep the focus on addressing these inequalities. So moving on to the next slide, really, it's just to show us that as we work together, there are many tools that we have in our Population Health Academy, sort of on the web page, on the sort of forum, but also in our discussions. And today, really, what we're going to focus on in a bit more of the tools that are available to help you, those that are available in Sussex, but also wider from a regional point of view and also nationally. We will hear from, obviously, Dr. Abraham George. I know George didn't introduce all the main speakers, but Dr. Abraham George will talk to us from Kent County Council about public health perspectives on population health. Sarah Pearce will be talking to us about some of the tools. She's one of our colleagues from the Office of Health Improvement and Disparities, or OHID, in the Southeast. And Kat Sykes, we know very well in Sussex. She's working with the Health Innovation Kent, Surrey and Sussex, like George is, but she's really worked within our system to help us to develop our digital inclusion framework. And obviously we have George, who we know from the first webinar, who is very interactive around these sessions. So do drop any comments, any feedback, any questions in the chat. And I know that George and colleagues from Health Innovation KSS will help us to navigate those queries. So lastly, really, what I wanted to do is, and we know these sessions can be long, and we know that we could actually talk to you for a long time to come around population health, but we will really need to keep these webinars to a focus. And so, as I said, we've organized in terms of the output of these webinars in the 3 webinars that I've outlined, but also in this session in terms of the 3 aspects. But here are a couple of tools that we aren't covering specifically today. And the first is the Sussex Integrated Data Sets, or SID, as it's known, which is our local set. We do have SID colleagues who might be joining us on the webinar today who can link in with you about what we have in our data resource so far. And SID has really linked data sets from community, mental health, physical health, or acute trusts. And there are some levels of data coming in from social care, and it also has linked us to primary care. So really, when you look at data sets, whether it's around cardiovascular disease or respiratory, the aim really is to look at a whole person across their entire pathway across the system. And that is our goal in the SID program. We also have many other tools like PAPI, which is a population and person insight tool. It's a national tool that was developed by NHS England. It is outcomes based, and obviously we can also drop links to that in the chat. If you don't yet have access to NHS Futures, then do register to access NHS Futures platform, because it has a host of information on it, and also very much managed through NHS England, with support of the NHS England's Health Inequalities team. And I'm a member of the NHS Health Inequalities National Forum. So of course, if you have any questions that are nationally related, I will be able to represent us there as well. So I think without further ado, I'll hand back to George, but thank you again for joining us. And I really do hope you benefit from today's session. Thank you, George, back to you.
Thank you very much, Tanya, for that whistle-stop tour. I mean, evidently there's lots happening and there's lots to do and lots to get involved with. And thank you also for your kind words. Evidently, there is an abundance of tools, and population health without tools is like navigating a vast sea without a map. But equally, you might argue that there are so many tools, where do I start? And we recognize that we will not be able to cover every single tool that exists to support a population health approach, but we've identified the key tools, the ones that you can access nationally, regionally, and even locally to support you on your journey. Also, this is an interactive experience and session. We can see colleagues are sharing information on work that's happening. I can see Vicky Gimson has shared some information there around the work happening with refugees, asylum seekers, and non-English speakers and travelers. So thank you for that. So any insights or tools that you're aware of, because we recognize we'll have blind spots, please do share. So without further ado, we're going to go to our initial interactive session. And this is a self-rating assessment, essentially a pulse check, for us to gauge where you think you're at in terms of your levels of confidence with regards to the topic that we are covering today, namely tools for population health. This will be a familiar exercise to you because we did it in the last session, but this time focusing on tools for population health. So there is a range of responses there you can pick, from very limited knowledge and not confident at all through to extensive knowledge and very confident. You might feel like a guru when it comes to these things and tools for population health, or you might be slightly in the middle, just dabbling in some of those tools, but not having a vast understanding or awareness of what they are. So help us gauge where you think you're at, because this will help us in terms of what we share, what tools we share, and how we shape the wider training offer going forward. And we'll do another similar pulse check later on to see if that has changed. Now, without further ado, time to introduce our next speaker, who Tanya alluded to earlier, Dr. Abraham George, public health consultant from Kent County Council. So this is not just an insular session looking at what's happening in Sussex alone, but we're also looking at good practice from other parts of the region and the country. So it's a privilege to have Abraham with us. Abraham's going to talk to us about population health management and key public health perspectives. So Abraham, over to you.
Thanks very much, George. Yeah, so morning, everybody. So I'm pretty sure I can't do justice to the full extent of describing population health management. There are so many different examples and tools that are available. I will try my best to sort of summarize and give a brief overview of the journey we've taken so far in Kent. So essentially, I'm a consultant public health based at KCC, and I've been associated with around the population health management program, working with the NHS over a number of years. And we've been spearheading also in linked dataset development even earlier on, of which some of the reflections around that of the linked dataset development, I would say, has contributed towards the thinking around the National Program for Population Health Management. As Tanya mentioned, it's extremely useful for everybody to get onto NHS Futures platform. There is a wealth and a plethora of resources and learning materials around population health management, and also case examples and experiences across the country around how different areas are actually undertaking population health management. Before I go into population health management, I just wanted to describe what population health is, broadly speaking, and then go into population health management. So population health is the definition is, the King's Fund has actually come out with a really succinct definition of population health, which is essentially the interconnectedness between four pillars of population health management, which is wider health determinants, an integrated health and care system, the places and the communities that we live in, and our health and behavior lifestyles. It's these things that actually drive population health. Population health management is simply the mechanism in which how we actually deliver population health. And the national program is sort of promotes the concept of, or the framework of population health management, divides it into four pillars, starting with infrastructure. So this is really about all of the different systems that's required to actually bring about population health management. Most notably about having a shared and a collaborative digital and data infrastructure, moving towards having actually, for example, a shared care record. And I'm pretty sure that quite a few health systems across the country are actually using their shared care record as their mainstay for accessing information about their population around and actually analyzing their population health needs. So it's around having that linked data set architecture and apps, and of course, simply having the data set is not enough. You would need to have the right sort of process and procedures to access that data in a safe, secure way. And so information governance for whole system data sharing and processing is absolutely important for that. Once you've got all of the linked data set available, then you need to actually have a sort of collaborative approach for analysis that would be a sort of wraparound kind of approach in terms of accessing that data. So that would mean then it's not just the purview of, say, the public health team and public health intelligence team and local authority doing analysis. It's the public health team, intelligence team in the local authority working in collaboration with, say, with the ICB, with analysts in provider trusts, working in a collaborative fashion to actually interrogate the data using the best possible advanced analytical tools, and some of them I'll be talking about in very shortly, and actually then doing the sorts of analytics that actually then enable population health. And it's not just simply looking at where health inequalities are, but actually going to the next step, which is actually, can we actually do case finding and actually re-identify those particular patients in the population that require those kind of prevention interventions, and then actually using that data then to evaluate impact, looking at how whether interventions that we deliver in population health management are actually working, and then how do we actually incentivize the system to actually reallocate the resources, which are very much focused on reactive healthcare. Can we shift them back further upstream to actually preventative healthcare? So it's using data in all of those kind of multi-dimensional way. And so when we're using that intelligence, we are actually designing interventions. So this is all about care model design, an asset-based approach to community well-being, co-producing those interventions with the patient and public, so that we're not developing them in isolation. And as I've mentioned again, evaluating the impact of those interventions. And as I said before, also the final pillar is around incentives, making sure that contracting and the payment models are all incentivizing prevention, and making sure that we have the right sort of workforce in place to actually then deliver those kind of interventions in place. So as just to reiterate what we've discussed I'm presuming in previous webinars, why is population health management important? So population health, health inequalities, and the wider health determinants are the key strategic goals for integrated care system. It's the way of working, utilizing data and insight to understand population health needs, creating the evidence base for targeted action, drives the design and delivery of sustainable, proactive, personalized care models. And it's also a measurable focus on prevention, and it's about mitigating downstream risks to ill health and hospitalization. Models are created and sustained through a partnership working through place-based teams with enabling functions and devolved decision-making from integrated care boards. The payments and incentives should be tied to population-based outcomes through collective and targeted use of resources and measurement of impact of those new care models. So again, it's all reiterating the same messages that I've mentioned earlier in that framework in terms of those 4 pillars. Again, we've talked about, Tanya's mentioned about the importance of tackling health inequalities. This is a key aspect of tackling or a key purpose of population health management. And actually, the COVID-19 pandemic was a very good illustration of how we broke down a lot of barriers to actually start working collaboratively together to identify those who were at greatest risk of COVID-19. And so integrated teams could actually target proactive support and to ensure equity of access to services. But at the same, and because it was not just about access to healthcare services, it's about identifying those people who are actually particularly were from the more deprived areas, where the underlying determinants of ill health were actually were having a more impact in terms of the health of those patients. So it's really about working with those neighborhoods and communities in terms of improving and tackling health inequalities. So population health management is not just a simple step, it's actually a cycle, and it's an intelligence led approach. when you're doing population health management, you're actually understanding, you're trying to understand and assess population health and care needs. The first step is around population segmentation to understand the specific needs of the population, looking at the impact of wider determinants, exploring gaps in care, unwarranted variation. This is, in fact, a regular task of and a function of local authority public health teams working with integrated care boards or CCGs as we used to call them, and we regularly carry out health needs assessments to actually do this kind of work around understanding population healthcare needs. One of the more advanced tools that have been promoted in the population health management program is around how we segment the population in a particular way, looking at people from, say, ranging from mostly healthy to people with long-term conditions or multiple long-term conditions, frailty, with disability. So there is a tool that's actually been developed by a national consultancy called Outcomes-Based Healthcare, where they've actually segmented the population, and it's actually what Tanya mentioned, which is the population and person insight dashboard, which has been set up by NHS England, but actually a version of that has been also piloted in local health systems, and Kent was one of those systems that trialed it over the last couple of years, which I'll come into shortly. After we assess the health and care needs, we then undertake risk stratification and impactability modeling. So this is all about identifying those high-risk patients, those emerging risk groups that are most amenable to interventions. And I'll come into very shortly a very short example of one of our primary care networks, one of our PCNs, where they've actually tried to do that. And then once you've done your case finding, then you're also using that same data to actually do some modeling to understand to assess the mitigated and unmitigated financial risk in the system. So what you're trying to do is incentivize those kind of preventative interventions and then reallocate resources further upstream. The fourth step is about designing and beginning to implement those interventions. So it's about multidisciplinary cross-organizational interventions that are targeted at those appropriate population segments through a biopsychosocial approach. And then fifthly, then it's all about whole system impact assessment. So this is where the evaluation bit comes in. So you're monitoring and evaluation to see whether cost and outcomes are actually changing over time. And so this becomes a cyclical process. So how we use data, and right from the beginning, it's the golden thread is actually it's a data-driven approach. Data is being used at different levels for different purposes. At a system level, as I mentioned before, we're using data to actually do a lot of modeling or actual projections to look at changes in population health and care needs and mitigate how health and financial risk across different care settings. So this helps in terms of the driving the most appropriate resource allocation across different providers and places. And then that's at system level. When you go down to place level, we're actually trying to identify high and rising risk cohorts. So that's actually where the segmentation approach comes in. And then we do a lot of benchmarking and variation across different providers and population segments. So there's a little bit of predictive modeling around the looking at the impact of those different interventions, calculating return on investment. So again, there's a little bit of and that translates into resource allocation within particular providers. So, for example, social prescribing delivered by voluntary organizations. And then at neighborhood level, then we're drilling down within those segments to do risk stratification and impactability modeling to support proactive case finding. And this helps in addressing some of the unwarranted variation by segments. So this helps in driving in terms of closing gaps in care, addressing the specific health inequalities, and engaging people in their care. At the person level, and this is where frontline clinicians are particularly interested in, is how they can use those data to actually look at the level of care and the extent of health for individual patients. So there's something called it was coined by the Nuffield Trust many years ago. It's called theographs. So basically looking at, and I've put in a snapshot of what a theograph looks like at the bottom of the slide. Basically looking at how many times a patient is how many touch points in terms of a patient is accessing the system, in terms of whether they're coming in contact with a general practitioner or with accident emergency or being admitted in a hospital. And that really helps in terms of some of the understanding of the extent of the intensity of care, and whether there was any opportunity to actually prevent some of that reactive care, and then focusing more on preventative care and reducing that the number of contacts of the patient with the system. So I'm going to go into a little bit about the emphasis around data. Data is absolutely important in this. So and the mainstay around population health management is around the design and development and accessibility of a linked data set for population health analytics. I think Tanya and George have mentioned about the and I believe there will be some colleagues talking about, or will be available to discuss about the Sussex Integrated Data Set, or SID. This actually, and I many years ago I was actually involved in the very early stages in terms of the development conceptualization of the SID. Actually, it was because it was based on or rather, it was based on some of the learning we had in Kent, because we developed a similar linked data set called KID, or Kent Integrated Data Set. Fast forwarding now, actually, we've got we've got multiple number of linked data sets actually in our disposal, where we use that for population health management. But essentially, a linked data set is data that is being linked at person level through the NHS number, usually pseudonymized. That is basically hospital data, community health data, data from general practice, community mental health trust, and then data from the local authority, particularly social care. And what I think is the real challenge now, particularly in two-tier systems like ours, where we have both a county council and district councils, data from district councils is something that is of particular importance, given the significant number of services that they deliver for that are sort of linked to population health. So, as I've mentioned before, one of the first in the first pillar of population health management is about the importance of having governance arrangements. So it's important to have good governance within your systems, so that gives trust and confidence, and gives oversight in terms of broadly all of the data sharing that's going on in the system. So we created something called the Shared Health and Care Analytics Board some years back, to act on behalf of our integrated care system, to provide that oversight, manage a single process or an operating model for linked data set development and access. So broadly speaking, the uses of linked data is around population planning, implementing population strategy, managing finances, quality outcomes, risk stratification, optimizing patient service flows, undertaking research, and also for public health intelligence. We've recently reconstituted our SHAB, and now it's got more clinicians and senior leadership within the sort of high level group, within the steering group, so that that decision making powers are more reinforced. So alongside the SHAB, and what it does, it also does is it oversees some of the collaborative working around analytical between different analytical teams. So we have, and this actually started very much actually during COVID time, when we were actually compelled to work between the council, the NHS, and at that time Public Health England, to start using data to actually understand, identify those high risk groups that were at risk, higher risk to COVID. So that's actually started to post-COVID, we've tried to retain those connections, those networks, and we're trying to work together in a systematic way. In that regard, we've developed some blended roles and training placements, working with academia, building up that, also linking into developing that sort of research and development function within the integrated care system. And so now we've got that analytics partnership, and we're working quite closely. So our public health intelligence team, for example, in Kent, works with Medway Council, works with the analytical team in the ICB, and also the analysts representing the different healthcare partnerships in Kent. There are 4 healthcare partnerships, and they're all largely supported by the provider trusts. This is just an example of some of the data that's been, when you've actually crunched the linked data set, you can come out with some very colorful dashboards, which can be color coded to actually identify those high risk patient groups, and or where there is high intensity or high spends, and that actually helps in terms of understanding that population health needs. And this slide is actually showing, roughly speaking, how one particular PCN started that work around applying those population health management concepts, using the data, identifying a particular high risk cohort within a certain age group, within a certain level of long-term condition complexity, and then through a logic modeling process, they started working together to identify the most appropriate interventions to actually then think about, okay, well, what are the right sort of preventative interventions that could actually tackle those particular health and socioeconomic conditions that we're having. But the important thing was about the effect of also wider health determinants and health inequalities, particularly the effect of smoking and the effect of deprivation and the level of poverty. So it's important when we're doing population health management, we have to think about the sort of key public health principles that actually drive a lot of population health management work. One of the things that's really important is what we've been very much focused on. I mean, what we sort of do in public health is think about the the population approach versus high risk approach. Population approach, for example, the seatbelt rule that we had that was instituted back in the 70s, reduced the numbers of people killed or seriously injured in road traffic accidents almost overnight. That's an example of a population-based approach that's applied to the whole population. And then you've got risk reduction or high-risk approach, where you're, say, for example, identifying a particular high-risk group that's actually then delivering a particular intervention for that. And a good example is some of the work we do around diabetes or coronary heart disease, or even, for example, reducing blood pressure. So a lot of the work that we do in population health management actually sits probably more on the high risk approach. So it's important to just understand from a perspective, where does that fit in? Where does population health management fit from in a broader public health setting? The other thing also we just need to bear in mind is the Robert Wood Johnson model. There's overwhelming evidence to prove that actually 80% of population health is actually influenced by wider health determinants, and only 20% is actually influenced by in terms of access to good healthcare. In fact, this is the driving force in which we are doing a lot of our public health and prevention work in Kent. And in fact, we're working very closely with our district council and their partners to actually start to emphasize around the importance of delivering a lot of preventative interventions that are related to education, income, good education, educational attainment, improving income, improving employment, the built-up environment, and behavioral determinants. This is another way of looking at it as well. This is the Dulger and Whitehead model that came out many years ago. This is about, again, it's a rainbow model just explaining and articulating the relationship between wider health determinants in terms of improving patient and population health. Again, access to healthcare is only a minority, represents only a minority element in that. And actually, it's the wider living and working environment that actually has the biggest influence in population health. The other thing also just to bear in mind is the prevention pyramid. So in public health, we have primary prevention, secondary prevention, tertiary prevention. A lot of the behavioral determinants that we deliver are actually sit in the primary prevention, which are largely population based. But actually, a lot of at the same time, what the role of, say, general practitioners delivering screening or health checks, they sit in the sort of secondary prevention side, which is all about early diagnosis and treatment. And then in tertiary prevention, which is all about dealing with complex cases, which is focused on rehabilitation, reablement, recovery. In fact, a lot of the population health management work that we do, probably sort of fits more on the secondary or more in the tertiary prevention, because we're dealing with somewhat very complex cohorts of patients. But actually, the role of health promotion and behavioral determinant is still relevant, and actually there is cross in between primary, secondary, and tertiary prevention. The other thing we just need to bear in mind that all of this work that we do in population health management is not just doing just treating patients, but we're learning on the go. So it's important to take a learning health system perspective in things. Learning health system focuses on approaches for capturing data from clinical encounters and other health-related events, analyzing data to generate new knowledge, and then apply this knowledge to continually inform and improve health decision-making and practice. So it's always important that we actually capture all of that learning that we're doing when we're delivering new interventions, treating new patients. The other thing also is just to bear in mind the importance of how the degree of difficulty, the degree of advanced analytics. It's actually through a continuum. So I found this sort of framework some years ago. It's called the Gartner Analytic Continuum. I just found it quite by accident in the internet. Actually, it's quite useful to actually frame our thinking around what and how we use data. A lot of the time when we use data, we're doing it to actually look at, say, surveillance of health inequalities, looking at trends of how, say, mortality rates or admission rates are going up and down over time, and helps, and to a certain extent that helps in terms of doing that population segmentation kind of analysis. And then if we are actually if we are really lucky, we've got that data all linked up, we can actually do a lot of what we call statistical analysis or regression analysis to look at the impact of what different factors, like the effect of behavioral or lifestyle factors, how does that in fact impact on the health of the population. So that's diagnostic analytics. But the real challenge that we're having now, in particularly, and that's being picked up in population health management, is the need to actually do predictive and prescriptive analytics, because it's not just about knowing what's happened in the past. We need to actually then plan for the future and actually use data to then re-engineer or reallocate some of that resources for prevention from the reactive care that's currently happening into further upstream to actually for prevention. And that requires us to use very advanced analytical tools like system modeling, which we are currently doing now in Kent. We're using something called System Dynamics, which I'm very happy to speak to if anybody's interested offline. Yeah, and then a bit about the population segmentation. So, this is linked to the population and person insight dashboard that's available nationally. We were part of a trial over the last couple of years to apply the same sort of segmentation approach using our own linked data set. And we were able to actually then segment our population into healthy, long-term conditions, frailty, dementia, organ failure, and cancer. And then what we were able to do is to move to see how those different cohorts change over time. So this is a moving piece of work. We haven't finished it yet, but we are actually trying to do this over a period of time to look at see how all of that insight helps us to then do a lot of that sort of financial modeling that I was mentioning earlier on. And then we're also working together collaboratively, informally, working with different teams to see how we can use data to actually help us evaluate impact. Even if we don't have a linked data set, there are still different methods like patient experience tools, survey tools to actually measure the impact of services in our local communities. But ideally, what we would want to do is use linked data sets to measure impact. And something called a matched control analysis is what I think is the gold standard if we can try and do that. And that requires a lot of resource, but it's something that we should aspire to. I think I'll stop there, and I'm happy to take any questions.
Thank you very much, Abraham, and how insightful. Evidently, population health management and its various facets is very rich, and there's lots there to digest and lots to utilize. And just to reassure you, in case you haven't been able to take all of that in, this session is recorded and will be made available, and the resources, namely the slides, will also be made available as part of a resource pack. Abraham, very quickly before we go on to the next speaker. Very quickly, how can I get, or how could anyone get started doing population health management, and what are the key enablers that will make population health management successful? If you could summarize that in about 20 seconds, how would you summarize a response to that?
Thanks, George. Yeah, I think the first step is, first of all, just have a sort of broad understanding of what your population looks like. So start with your public health team in local council. Public health teams actually administer what we call the Joint Strategic Needs Assessment, or JSNA. So basically, it's a requirement for public health teams to assess population health needs in a systematic manner. So and most of those JSNAs are actually online in a website. So if you go into that JSNA, you will start to look at your population health and also socioeconomic needs overall, and that gives you a good picture to understand your population to begin with. And that's not just at a, say, East Sussex or West Sussex level. You can actually drill down to, say, at a council level, or maybe even at a PCN level. And then that will start to generate more questions around some of the complexity of health needs. And this is probably where the starting to use a linked data set starts to become useful. So the Sussex integrated data set. Just to bear in mind that actually in the when you're trying to assess population health needs, your public health teams will be doing some specific analysis using data that they've sourced from elsewhere. But also, and I'm just not to steal Sarah's thunder, but there is also the national profiles available to also assess population health needs, which is what Sarah's going to be presenting in in terms of fingertips from OHID. So if you start with that, that's the best way to get cracking on population health management, and then you can start and then networking with key stakeholders around what would be the right sort of interventions to actually deliver population health management. Hopefully there is enough governance available. I mean, there's enough organizational work already going on to bring public health frontline practitioners and commissioners together to start doing population health management, and that's the work that we're doing in Kent.
Fantastic. Thank you so much for your time and for your insights, Abraham. And we know you won't be able to stay with us for the rest of the session because you've got another speaking engagement, but we're really grateful for your time, and the points you made there also resonate. In particular, having seen a comment that I believe Dr. Chris Odedu made around culture and creativity. So the stakeholder engagement piece and networking with colleagues is essential to not only looking at social health determinants, but more broadly, how we make population health management happen effectively in our areas. Now, without further ado, introducing our next speaker, Sarah Priest, who's the Principal Knowledge Transfer Facilitator from the Office for Health Improvement and Disparities, also known as OHID, who's going to give us an overview of fingertips, not the anatomy of the fingertips on our hands, of course, hashtag dad jokes, but fingertips, the public health data tool. So Sarah, over to you.
Thanks very much, George. So hello, everybody. So thank you very much for inviting me along today to give a bit of an introduction to the Fingertips Health Intelligence tool. Yes, I work for the Local Knowledge and Intelligence Service, which is part of the Office for Health Improvement and Disparities, which used to be Public Health England. And my role in particular within the South East region is to support the Sussex system, which is one of the reasons I'm here. So let's move on. So obviously there's not going to be time to run any training as such on fingertips. This is just a very, very brief sort of overview to increase awareness of the tool if you're not already using it. And if you are, perhaps to increase your understanding of using the tool and how it could be useful in your work. I have developed a slide pack to accompany this session, which will be uploaded to your resource centre sort of after today. And it will have some information on our national training programme on fingertips. And also we have a South East region monthly training sessions on different population health tools, which you might be interested in coming along to. And also it will highlight some e-learning on e-learning for health under the Population Health Management Programme, which focuses on public health intelligence. Okay. So we've heard a lot already about sort of data to decisions and how the importance of intelligence in population health management. So this is really just to highlight where the population health intelligence tools fit in this sort of continuum, taking that data through to actual intelligence that we can use, we can access quickly and easily, and target our interventions effectively. So moving on to fingertips. If you're not aware of it already, I think Abraham's already given a good introduction, so thank you very much. It presents a wide range of data related to population health for different localities. So you can use it to compare data between areas, or you can use it to look at compare to a chosen benchmark, such as England or the South East region, and you can look at the data over different time periods. So it helps you to highlight any issues in your local population, in your local geography, and can help you to effectively target your sort of services or interventions to reduce health inequalities. So what can fingertips be used for? It can be used for health needs assessments, which we've heard discussed already this morning, any service planning, developing funding applications, and generally in informing population health management decisions. So I'm going to move on now and do a little demo on the fingertips tool. So if you haven't used fingertips before, it's quite easy to find. You can just Google OHID fingertips and it should come up. And as was mentioned, it basically is the data is presented by a range of different profiles. And these profiles, as you can see on the home page here, are grouped into different topic areas. And I thought it might be helpful today to do the demonstration from the perspective of a sort of case study. So I'm imagining that I'm doing work around cardiovascular disease, and I want to reduce inequalities in prevalence of cardiovascular disease. Now you can see there is actually a profile here on cardiovascular disease, but I'm actually, ironically, not going to go through that today. As an example, I'm going to show you the public health outcomes framework, mainly because this is a very large profile with a wide range of indicators and a wide range of different data views. So it's sort of a useful one to demonstrate. If I have time, I'll also go into the national general practice profiles. So if you are using fingertips and you get a bit stuck and you're not sure, you've got some questions, you don't know how to use it, there is a guidance page at the top here where you can download a how to use guide. So I'm going to click on the public health outcomes framework. And for every profile, you get a home page with some information. And you can see that the public health outcomes framework is split into 4 main areas. So you've got those wider determinants of health, which were mentioned earlier, health improvement factors, and health protection, as well as some data around healthcare and premature mortality. So to get into the tool, you just click on Start, and it will default to an area profile. So most of the geographies in fingertips are actually based on local authority boundaries. And if I click on the geography here, area type, it shows you can look at an England level, you can look at a regional level, you can look at counties and unitary authorities or districts and unitary authorities. Now, we are beginning to get more data at an ICB, an ICB sublet location level. But some of the profiles are particularly focused on NHS geographies, such as the general practice profile, which I'll show you if I can shortly. So we're going to stick on counties and unitary authorities. And we want to look at them by the South East region. So I'm just going to change that to make sure that's in the South East. Good. So at a starting point, what the best data view might be to look at up here is the overview. So this will look at the indicators down here, and it will show you the values for the indicators across the South East region, or whatever you've chosen up here. And so we've got England, South East, and each of the counties or unitary authorities across the South East. Now, my starting point in this particular case study is looking at premature mortality from cardiovascular disease. So if we go into the topic option here, we can see that it's split into those 4 main areas of the public health outcomes framework. So I'm going to choose premature mortality there. And if we scroll down, we can see there's a couple of indicators which might be relevant. We've got under 75 mortality rate from all cardiovascular diseases and from those considered preventable. Now, if you haven't looked at these sort of charts before, basically it provides you with, let's say, an overview of the situation across whatever area you're looking at, in this case, the South East region, counties. And the colours are related to RAG rating, so it's red, amber and green. And so the green is whether they're significantly better than whatever your benchmark is, similar or significantly worse. Now the benchmark up here defaults to England. Now, because in the South East, quite often when we compare to England, we come out fairly positive. And we're looking at inequalities across the region. So it might be better to actually compare to the South East region. And as you can see, those colours have changed quite a lot. We've got a lot more reds there. I'm going to turn it back to England. Now I'm particularly interested in the Sussex area, so I can look across and see what the rates are. So Brighton and Hove, which is similar to England, but it is actually higher than England and it's higher than the region. And then we've got East Sussex, which is lower than England, and West Sussex, which is also lower. Now, we might be thinking that actually those are quite high level geographies. So it might be better to have a look at the district level. So I'm going to change this here to districts to see if any inequalities are shown via districts. Now I'm just going to change this to a compare areas view. And I'm going to change the indicator here to E04B. So we're looking at the same indicator. So this data view helps you to, at a glance for each indicator, you can compare across your chosen area. And scrolling down here, we can see that Slough is the highest rate in the South East region, but Hastings is right up there. It's second highest. And obviously Hastings is in East Sussex, so that might be of concern to us. As we go across, we have the RAG rating again, so we can see it's actually statistically similar to England. If I change the benchmark to the South East, you can see it's actually significantly worse than the South East. Now we'll highlight these confidence intervals here on the chart, which you can see listed here. So the true value could actually range anywhere between these 2 points. So just to bear that in mind, a note of caution. So which is why it's statistically similar to England and not worse, significantly worse. Okay, so we've had a look at geographical inequalities. What you can also use the tool for is to look at inequalities in population groups. So if I go up to the inequalities data view here, then each indicator is broken down by different inequalities. This particular one has deprivation and breakdown by sex. But depending on the indicator, you might get a lot more. You might get socioeconomic group, ethnicity, age, and so on. So this shows you the rate, how those rates vary by different population groups. And this shows a quite clear association between deprivation and this particular indicator. So again, we've got that RAG rating against England. I will highlight that these figures are at an England level. Sometimes you can get the inequalities breakdown at a local area, but they're mostly for England, but we can still extrapolate, to your local area. So we can see that those who are living in the most deprived decile have significantly higher rates than those, and those in the less deprived deciles are significantly better than England. Okay, so having looked at inequalities in populations, we notice that Hastings had a particularly high rate. So let's have a look at Hastings. So I'm going to change the data, the area to Hastings. And I'm going to go back and look at an area profile. So this is a bit of a snapshot of the Hastings area. Now, at this stage, I'm thinking, what might be driving that apart from health inequalities? What about lifestyle risk factors? So I'm going to change the topic area to health improvement. And as you can scroll down, you can choose indicators that might be of interest. So we've got here dietary indicators around fruit and vegetables, and overweight and obesity, physical inactivity, and smoking prevalence. So if you haven't seen these sort of SMINE charts before, then just to go through it quickly, you've got the most recent date there for the data. You've got the value for your local area, for the region, and for England. And these values here show the complete range across England. So you've got the red line is for England. You can change this to the southeast region. And again, they're RAG rated against England. So if you've got a red dot, it's significantly worse than England. And the negative is always to the left of the red line, and the positive is to the right. So if you've got a dot over here, it's not going to be good. So for these particular indicators, we have got a red dot over here. But if we look at this indicator, it's an old one. It's an old methodology and an older data. So it might not be appropriate to use that one. But the more modern version is sort of in the middle somewhere. But what does get flagged up here is the smoking prevalence. So this is the annual population survey for 2022. And we can see for Hastings, the rate is 23.7%, which is a lot higher than England at 12.7 and the region for 11.5. So it's not significantly worse than England, but that's probably because of those wide confidence intervals. So we might want to focus on smoking. If I click on that, we can go back to compare areas, and we can see that actually Hastings has the highest rate of smoking in the southeast region, followed by Crawley. But again, we've got these wide confidence intervals, so a note of caution. But we do know that smoking prevalence is linked closely to deprivation. So obviously, if you're working in the area, you would know about levels of deprivation in those localities. You may want to think, well, is this just a one-off rate? What about over time? Has it consistently been higher? So we can go into trends here, and we can look at that indicator over time compared to England or compared to the region. So we've got the England rate here and this rate here for Hastings. And as you can see, it has consistently over time been higher than England. So it clearly is an issue. You might think it goes up and down a little bit here. This is probably due to we do have these wide confidence intervals. If you're concerned about the data at all or data quality, then you can go up here into definitions, which is a really useful data view. It gives you a lot of information about the indicator. And as I scroll on data sources, and as I scroll down, you can see it's got caveats. So if you're concerned at all, then recommend looking in there. So that was really what I wanted to show you from the Public Health Outcomes Framework. I think I've just got a few minutes left. So I'm going to go back to the home page. I'm going to the National General Practice Profiles. Start. So we were interested in Hastings, so I've already set the geography to the Hastings and St Leonard's Primary Care Network. We're going to area type. You can see here that the data in here is presented at GP level, primary care network level, ICB sublocations and ICBs. And the majority of the data is the QOF, Quality Outcomes Framework data, which is why it's at those geographies. So another thing you might be interested to know is you've got a practice summary here. If I change this to compare areas, so you can look at your practice. Oh, actually, I'm going to go into overview. So it's got some indicators relating to the actual practice itself. So if I am wanting to find out which GP practices are in the most deprived area, we have got this indicator here for deprivation score per the Index of Multiple Deprivation from 2019. If I click on the legend, you can see that particular indicator has been split into 5 groups, into quintiles nationally, with the the lowest score, the best or least deprived, and the most deprived in the darkest purple. So if we look across here, we can see that we've got 3 in Hastings PCN that are in the highest quintile here, but the others are in the second highest. So clearly there's that's some evidence around deprivation, which obviously links to all the other indicators we've been looking at. And that particular indicator is based on where the patients are registered, not where the GP practice is. So finally, I was just going to show you the different topic areas in this particular profile. We've got some more risk factors for CVD here. You've got the QOF data around obesity and smoking prevalence. So, and you've also got the general practice survey for a smoking prevalence. So you've got 2, in fact, you've got 3 smoking prevalence indicators altogether in the tool. But you can, obviously this might be useful if you want to look at GP practice level data. You've also got other risk factors for CVD. You've got hypertension, QOF prevalence, and you've also got some indicators around managing hypertension. And just quickly then, just to highlight, you've got CVD prevalence indicators here. You've got stroke and TIA, and heart failure and atrial fibrillation. So obviously, we talked earlier about the SID, the integrated data set. So you would want to use that in conjunction with this. This is possibly more of a starting point. And then when you want to look, you've obviously got access to your local data, which you would want to use. And really to emphasise that Fingertips is only one tool of many. You would probably want to use a range of different tools. So you've got the NHS tools, such as the Health Inequalities Improvement Dashboard, and other tools that are here, as well as the NHS produced. And I've put information on those different tools into the slide set. So if you're interested, then have a look at that after the session. So I think that brings me to the end. And I think we were going to do a quick Slido quiz, and then we'll look at any questions that have come up. Question is, what could you use Fingertips for? Yeah, needs assessments, service planning, funding applications, or informing population health management decisions. So it looks like most people have put all of those, which is perfectly true. Yeah, and I'm sure there are other things you could use it for. So let's move on to the next one. Which of the following are topics within the Public Health Outcomes Framework profile? So if you can remember this, wider determinants of health, health protection, health improvement, or all of them. So I'll give you a few seconds to answer that. All of the above. Yeah, definitely. That's correct. So it has got wider determinants, which might be useful. What does a red dot on an area profile mean? I like the picture. Significantly worse than the benchmark, highest rate in the region, or cannot be compared. Right, so yeah, it's significantly worse than the benchmark. So if it was significantly better, it would be green, or similar, it will be amber. So well done to most of you who got that correct. So next one. Is primary care network level data available in the National General Practice profiles? So I'll give you a few seconds to answer that one. Yes, for most of you, yes, it is. So it's in the general practice profiles. You can access data at GP level and primary care network level, as well as ICB sublocations and ICBs. So well done to those of you who are obviously watching. In which data view would you find any caveats relating to the data? Yeah, most of you have got that correct. It is the definitions. So that's the page that basically has all the information about each indicator. So is that the last question? Yes, that was. Okay, well done, everybody.
Thank you so much.
I think they were listening.
Yes, we were indeed. What we were missing was probably some countdown music in the background.
Yeah, I was thinking that.
The quiz was going. So thank you so much, and a really useful insight into Fingertips, and hopefully as and when you share information on the training sessions that become available, then we can share those with participants and the wider system. We do have some questions, and there's one which I'm personally intrigued to know the answer to, is does smoking include vaping, the smoking prevalence data on Fingertips? Does it include vaping as well?
That's an easy one. No.
No.
It is
Right.
smoking. It is not vaping. We don't have an indicator on fingertips for vaping at the moment. There are various surveys out there on vaping prevalence, which are published, but it's not an official. There's a long process to get an indicator onto fingertips, so it would have to go through that official sort of process to get onto it. So it's not there at the moment.
Thank you. That's a nice and easy one. Got a couple more questions actually. So, how often is fingertips data updated in the tool itself? What's the frequency?
Well, the fingertips tool has an update every month, but the update includes any data that has been updated. So let me say that again. When we get new data for any particular indicator, it goes through to each profile team that's working on each of those profiles, and then they'll obviously do some further analysis. They might be converting it to a rate per 100,000 population or something like that. So they'll do analysis for it and do a lot of quality checks, and then it will be published. So if it comes out in October, it might not get in there for a couple of months. So it may not be immediate, but it will have gone through all the quality checks and everything. And then each month there is an update as such. So it will be, so it will go into the next month's update.
Brilliant.
So I don't know if that answered that very well, but it is updated when there is new data. And look out for it. It's the first Tuesday in every month. It will have the new data come up.
Fab, thank you for that. And I guess once that data is uploaded, or any data is uploaded, can any user, a novice to an expert, download the charts from fingertips directly?
Yes, you can actually. Yes, you can download the sort of data tables and charts by going into it says more options just above the charts. But we also, if analysts want to access the actual data, they can do that. There's an API, it's called. If you look at the black ribbon at the top of the screen, it says API, and they can go into there and download that using code.
Brilliant. And there's a point of clarification here that Jenny Hacker shared. Is it important to clarify that although updated monthly, lots of the data have different time frames? Some might come quarterly and some annually and so on.
Yeah, all the data on fingertips is annual data. So if you get the NHS data, like Stop Smoking Service data or smoking at time of delivery data, that comes out quarterly, but it's only the annual data that is updated, so it'll only be updated annually in fingertips.
Brilliant. Thank you once again, Sarah, and I'm sure everybody, or I hope everybody's found the session useful and the information on fingertips, but more importantly, how to navigate the platform itself. And we've posted in the chat the guidance document that you referred to earlier for everybody to access. And we look forward to seeing links and information on
I will send
the
those
training.
through. It's starting next month. We have got a couple coming up soon, but they're all fully booked. But we'll have another batch released next month. So.
Fantastic. Thank you so much. And I'm sure many of you now will want to take a comfort break to stretch your legs or get something warm to drink, or just give yourself a break from the screen, because we've been on here for some time now. So we're going to do just that for about 9-ish minutes, 10 minutes. So we'll be back by 11:25, ready to listen to our final speaker of the day. Kath Sykes will be talking to us about one other tool, namely the Digital Inclusion Framework, and how digital inclusion and health inequalities are being addressed in Sussex. Welcome back, everyone, and it's really heartening to see that we've still got most of you here on the webinar with us after our comfort break, and excited at this point to be introducing to you a colleague of mine, actually, Kath Sykes, who wears a couple of hats, namely the implementation lead for one of the applied research collaboration themes for the NIHR, and is also leading on some work that she'll talk to you about around digital inclusion and health inequalities, and will be introducing to us the Sussex Digital Inclusion Framework for Health and Care, which was a bit of a mouthful as I tried to say it there. But Kath, I will not try to steal your thunder. Over to you now as you talk us through the framework.
Thank you very much, George. So I think I'll just crack on, but just say I am a clinician by background and have worked in sort of London and Sussex for 30 years in the health and care system. So I'm very passionate about innovation that really supports our health and care system, but also obviously our workforce too. So I'm just going to share my slides. Okay, so I'm going to firstly just talk a little bit about digital inclusion and health inequalities. So what we know is that there's obviously been massive transformation, digital health and care, in particular since COVID, and it really does have the potential to empower people to manage their health and care better and improve effectiveness, outcomes and efficiency. But we also risk excluding the most vulnerable and highest need populations, including populations that would most benefit from digital health and care, and perpetuating or exacerbating health inequalities. So we know that millions of people in the UK are unable to access essential services. This isn't just health and care, this might be local authority, services as well, banking, education, digitally. And the real challenge we've got is that we don't really know at the moment, we haven't got the data to show who is being excluded, who's being underserved, where they are, or what their health status is. So when we talk about digital exclusion, we talk about lack of access, lack of skills and capabilities needed to engage with digital devices and services. But there are additional factors in health and care, and that might be lack of privacy, but also, very importantly, the health and care system is recognised as one of the most difficult organisations to navigate digitally or in person. The Good Things Foundation have some really great resources and insights into some of the challenges. But what we do know is that if you are digitally included, you really reap many, many benefits. You're much more likely to be healthy, you're more likely to be saving money, you're more likely to be happier, you're more likely to be able to access jobs and education. So there are real benefits from being digitally included. If you're excluded, then you obviously have increased costs because you can't search for better value products online, as an example. And we know that people who are more likely to be offline are more likely to have a disability or health condition. They're more likely to be older. People who are limited users, so they're using the internet in very, very limited ways, are more likely to come from low income households. They're more likely to be minority ethnic groups. And there's factors obviously such as cost and language that come into play, but it really does put people at a big disadvantage if they are digitally excluded or disadvantaged. So we do know some people are more likely to be excluded. We know this is older people. So people in particular, if they're over 75 years old, they're more likely to be excluded if they don't have adult children as well, or living alone. We know people in socioeconomically disadvantaged groups, people experiencing homelessness, in insecure housing, obviously disabled people, people living with life-impacting conditions. People living in rural areas, so anywhere with inadequate broadband and mobile data coverage, so that's rural and coastal areas. I live in Brighton. There are certainly pockets even within Brighton that you can't get mobile data coverage. People for whom English is not their first language, and people who've got a sort of lower educational attainment and lower literacy confidence and numeracy confidence as well. So you can start to see some of the challenges here because some of this data is quite difficult to collect. We and this is intersectional as well. So across our non-internet users, on all age groups, people are more likely to have a disability, they're more likely to be older, they're more likely to be worse health, poor, less well educated, and from low income households. And even when they are online, they are going to be included at a disadvantage. They're going to be paying more of the percentage of their overall disposable income on fixed broadband, as an example. So digital inclusion really is now considered a social determinant of health, so a non-health factor that is linked to health outcomes. And this isn't at all data-based, but this is just I suppose something to think about, that if we think that 80% of our population are digitally included, then we know they're more likely to be younger, we know they're more likely to be healthier and richer. So they might be accessing or using about 20% of our health and care system demand. But that 20% of our population who are digitally excluded could potentially, are likely to be a significant proportion of our health and care system demand. So we really can't afford to be ignoring this group. So we quite often talk about access and skills. We know that the digital divide is widening during the cost of living crisis. I've put links in this presentation. I won't go through all the data, but we know more people are cutting back on internet packages during 2023. But it is also just to recognise that internet access does not necessarily equal digital inclusion, and there are many other barriers that people can face, and that includes old technology, broken technology, or just using it in very limited and restricted use. The Lloyds Bank collects data every year looking at digital skills. So we know about 65% of our population have high levels of digital skills, but that does mean that 35% of our population have at best low digital skills. And when we talk about low digital skills, we're talking about accessing the internet in quite a limited way. So 25% have very low digital skills and 13% have ultra low digital skills. Of that 13%, they are more likely to be older in older age groups, and they are more likely to be earning have much lower incomes. I've touched on the complexity in the health and care system. We're not talking about one simple log on at the moment. I know we're working towards that, but people have to navigate multiple different technologies in order to be digitally included. And it's also about the pathway around it. So this is just an example of Fred, who's 80 years old, increasingly in frail health. He's got a couple of comorbidities. He started falling recently. He could benefit from the virtual ward. So if we think about what Fred would need to navigate in order to access digital health and care, he's likely to have to use his GP's website, the NHS app, a separate link for online consultation, his My Health and Care record for letters and results. He might get text messages. He might need a BP monitor to record his own BP and then upload that. He might have an app for managing his COPD, a different app for his strength and balance support. And then potentially, if he does go onto virtual wards, a different BP monitor, SAP monitor, and virtual consultation platform for virtual wards. So you can start to see how complicated this can be in health and care. Again, I'm going to share these slides with you, but we did quite a lot of engagement to develop the digital inclusion framework in Sussex, and looked at this in quite a holistic way. So there's lots of issues about trust. If things don't work, people giving up. People don't always understand the information. It's already too complicated. But also, when people get the help they need, they find it really helpful. But I think a key message is that when people are unwell or stressed, the last thing that they feel they can do is learn something complicated and new, and that is what we're asking people to do. Some local Sussex context. This is just some anecdotal sort of feedback. We had a volunteer who was supporting over 400 older adults living alone in Sussex, and he said that they have to send about half of them letters in the post if they want to share information, because they don't use mobile phones. We're not even talking about smartphones. They don't have or use mobile phones or email. So these people are not going to be accessing, the sort of reminders to check their blood pressure, as an example, via mobile phone text messaging. A GP in West Sussex talked about holding a menopause workshop. None of the 8 women who attended that were able to access the online resources. This is in a more deprived part of West Sussex, but this just goes to illustrate that we're not just talking about older adults here. And also that GP data doesn't, about 50% of this particular GP practice of patients on their books didn't have smartphones or email addresses logged. So although we know some people are more at risk of digital inclusion than others, we also know that everyone is at risk of digital exclusion over their life course. The King's Fund, a UK committee, is starting to recognise that. So as an example, if your financial situation changes, if you have a health issue like dementia or suffer a stroke, then this can really change your ability to engage digitally very quickly. So our premise is that we really need to start designing all our digital health and care services pathways and technologies to be as inclusive as possible, and consider all the diverse and complex factors that can lead to someone being temporarily or permanently excluded. We know that NHS England and our ICBs have a statutory duty to consider how to reduce inequalities, and obviously that's what this webinar is all about. But we do need to be taking steps to address the barriers to digital inclusion as a result. And NHS England have issued a digital inclusion framework. Our Sussex framework fed into this, and they've got 5 domains that they've identified, and that includes obviously access to devices and data, the accessibility and ease of use of using technology, the skills and capability, beliefs and trust, and leadership and partnerships as well. So this is this is a sort of policy system level challenge. Individual programs work are going to find this quite difficult to, we'll find it impossible to address this in their own services. So it does need that sort of policy level driver. So I was going to introduce our framework now. This was a collaboration between the University of Sussex, NHS Sussex and Health Innovation Surrey Sussex. We engaged very widely to develop this framework. But it is one of a number of tools. So I'm hoping that someone will pop the link in. If not, I'll pop it in at the end to the Digital Inclusion Framework and Assessment Tool. We've also, I think we've got Susie Goodbrand online, and she and colleagues have developed a digital inclusion population dashboard, which I'll show a picture of. That's in development. We're also doing work to develop industry-facing framework. So really helping our industry partners to really design with inclusivity in mind from the start. We've got colleagues in the Sussex Community Foundation Trust who are developing tools for specific services, including digital evaluation and assurance. And we're working towards digital inclusion policy and strategies across NHS Sussex. We've also working with national NHS England team to ensure that digital inclusion is integrated into the health equality health impact assessments. And there are also various projects and case studies that are available on the NHS Sussex intranet that talk about some of the projects that have been done across NHS Sussex to provide devices and skills training. So the Digital Inclusion Framework looks at digital inclusion from the perspective of the service user, although it does apply to workforce as well. So it looks at how they would engage, how they need to be aware of digital health and care, their consideration of engagement, their experience, and what really needs to be happening for them to continue to engage. So awareness is obviously the start. People need to be aware of what is out there and how it benefits them. They not only need to have the access to, but they also need to be able to afford the technology and any associated requirements for use. So if they are reliant on assistive technology, as an example, then this starts adding cost and complexity. They need to have the skills, and if they don't have the skills, then they need to have the support to access the technology and pathway. And although a lot of focus rightly is on improving people's skills, I think when you look at that complexity, this is quite a challenge, and we do need to start reducing the support requirements for people to access digital health and care by making it much easier for them to use. People need to believe that the effort required to engage is worth it, and some people will have multiple barriers to overcome. They might have affordability, they might have literacy, they might have language. So we really need to be sort of motivating people to see the benefits of digital health and care. Obviously, they need to trust that service, pathway and technology is safe and effective. They need to have access to accessible and usable pathway services and technologies that are easy to understand and interact with and work alongside other pathways and assistive technologies. And ultimately, they need to have confidence that appropriate guidance and support will be available. So this is the digital inclusion framework. Again, we'll pop the link in the chat. It is easier it's quite difficult to navigate this online, but what it does is it plots the main barriers and enablers to digital inclusion across across things like access and affordability, skills and support, motivation and trust. It provides in each of those areas, it provides a digital health and care, digital inclusion objective. It includes various recommendations and considerations, and it also identifies the populations that you would want to pay specific attention to in each of these areas. So this particular part is access and affordability when someone's considering using digital health and care. This one's about skills and support, and this is about accessibility and usability. So again, it's much easier, I think, if you access this via the link. We've also developed a digital inclusion assessment tool. So this is, whilst that sort of national work is going on to include digital inclusion into the Equality Health Impact Assessments, this is being used in Sussex alongside the Equality Health Impact Assessments to look at care pathways and technologies. We're very aware this works particularly well at sort of commissioning level. So that's why a lot of the other work is going on to develop tools for different parts of the health and care system, provider level, service level, and population level. So this just flips that patient pathway onto what the objectives are of the digital service pathways and technology design objectives. And it lists the enablers, the barriers, who to pay special attention to, and some recommendations. And then this gets plotted against sort of action plan. So it can be used either to evaluate existing services or to evaluate new services. So we've also used it for procurement and re-procurement as well. So I talked about the dashboard heat map and data in Sussex. So this is being developed by the digital team and the business intelligence team in Sussex to start trying to plot some of those factors that lead to that are more likely to lead to digital exclusion, and that will help target sort of population level support. So that's in progress. I can't give you a link to that today, but that is very nearly ready to be shared. So ultimately, this is still quite early days for digital inclusion. It is a national priority for NHS England, but we, like I said at the very beginning, some of this really does need policy and strategic commitment. The UK Parliament Committee recently recognised that the government doesn't have a robust strategy for digital inclusion, and some of this, I think we really do need to think about how we can improve access, how we can provide devices and data and Wi-Fi, in particular to our highest need populations. We've talked about improving skills, but it really is important to reduce the support needs to make digital health and care more sustainable. We just put pressure in other parts of the system if we're just constantly trying to upskill both our workforce and our population. So really reduce that complexity, and not just in a siloed pathway, but across everything that a person might need to interact with across health and care. We do need to obviously ensure that things are accessible and usable to the widest population possible, and we also need to enable feedback. This really came up very strongly, that people get given access to a website or an app, but there's no way to feed back in the same way you would be able to if you were doing something face to face. And this is really essential so that we can understand outcomes and experience and improve that. So we've talked a lot about data today. We are working as nationally and regionally to develop data sets that will help understand who's being included and excluded, and their impact on health outcomes, which is really obviously very important. And I think it's really important that we reduce that variation. That's part of that, reducing that complexity, but only commission the technology that meets the needs of the population it serves. The reality is that high-spec tech, much as it's very if it's a patient-facing technology, is unlikely to be inclusive, because it requires quite heavy data requirements, newer models of technology, and that sort of thing. So sometimes simplicity is better, and that's certainly what we're finding with some co-development work we're doing in dementia. So I'm going to stop there. I'm very happy to take for anybody to contact me. I'm hoping I'll just check that the link got put in the chat, but I'm happy to take any questions.
Thank you so much, Kath. Really, really insightful and really encouraging, really, to see the action and amount of work that's been happening locally to address what is now known as a national, even global challenge, one that I guess was exposed during the pandemic in particular, which you alluded to. So thank you very much. I was going to ask a question, again, in the interest of time, we won't be able to cover it. It was around what's happening nationally, but I think you've responded to that inadvertently through what you shared in your recommendation slide earlier. And there is a national framework, isn't there, by NHS England on inclusive digital healthcare, I believe. Am I right?
Yeah, they've got some user design principles. So the NHS England has got some really great resources to help us design inclusive technology. But I think I think we need to start shifting the sort of narrative away from just access and skills. The challenges are much wider than that. So we really need to think about it much more holistically.
Absolutely, absolutely. And as a system as well, have a plethora of tools at our disposal now. It's about how we utilize them, not in silos, but together across sectors, across systems, for the benefit of the populations we serve. Thank you so much, Kath, for the work that you're doing and for sharing with us about the work that you're doing. And we hope that many of us here can engage or get in contact with you about how we can work together on tackling digital exclusion in Sussex and hopefully beyond.
Thank you.
Thank you. And I did say, didn't I, that we'll blink and it will be the end of the session pretty much, but it's not quite that yet. We've got one more thing. We've got a final interactive session, and at the start we try to do a bit of a pulse check just to gauge where we think we're at in terms of our understanding of the population health tools more broadly. So a Slido link has now been made available, should pop up on your screen. Similar question to what was asked at the start, but this is to see if anything has changed since you answered the question before we started hearing the talks. So after what you've heard so far, how would you now rate your knowledge and confidence in tools for population health? Do you still feel you've still got very limited knowledge and don't feel confident because you need to go and test some of these tools out perhaps? Or do you feel you've shifted a bit and you've got a reasonable amount of knowledge but still not that confident? Or do you feel you've got a good amount now of knowledge and feeling fairly confident about applying the tools that have been shared? Or do you still feel like a guru? Have you shifted to guru status after all that you've heard? So there's an opportunity to respond to that there. And there's also an opportunity for you to answer a few questions before we wrap up. Really, we want to find out from you what you thought of the session, what we can do differently or better even, or what we can carry on doing to inform how we develop the offer, the training offer with regards to population health to everybody across our system, regardless of what organization they come from or the role that they hold. So you'll have a few questions after the baselining question, or the self-assessment question, should I say, for you to tell us just that. Very simple to do, star ratings for most of them. And for those of you who are super keen and want to remain engaged, connected, and actually help us tackle some of the challenges that we're aware of or working on, please feel free to share your email address in response to one of the questions that is on the Slido poll that has popped on your screen. So I'm going to give everyone a few seconds to complete that, and we'll keep the Slido poll open. For those of you who didn't get to do the Slido poll at the start, we will make sure that that is shared post-session. But as many of you as can right now, please, if you can answer those questions and respond to the poll, that would be very much appreciated. So give everyone a few seconds to do that. Once again, as has been said in the chat, all the presentations will be made available on the Sussex Population Health Academy webpage, together with the link and the video. And for those of you who like to stream media and are binge watchers, you can watch the first webinar along with the second, as and when those the link becomes available for this webinar. And we'll follow up with you via the communications that you normally get. So what's coming up next? So if we could have a slide up, thank you very much. So thank you so much for joining today. We're mindful that there is lots going on in our respective roles, areas, geographies, let alone Storm Isha causing havoc across the country. But we really hope that you found the webinar both enjoyable and insightful. And as I said earlier, we'll be sending you the link to the resource pack from the event shortly. For those of you who are on social media and like tweeting and posting things, please use the hashtag #PopHealthMatters. And look out for any post on social media to co-sign this as well. And of course, in addition to the feedback captured online today, if you have any other comments you'd like to share, please email my colleague, Jill Potts, whose email address is at the bottom, jill.potts1@nhs.net. So what's coming up next? Well, as Tanya said, and as I said, this is the sequel, part 2 of the series of webinars, or in the series of webinars, and the final webinar in this series will be on the 20th of March, which will be on what works where, looking at good practice or just practice in general with regards to population health and lessons we can learn from what's happening in Sussex and in the region, or even nationally and globally. So you'll get a sneak preview to what will be covered in due course, but looking forward to seeing you all there. Please tell all your colleagues and across your networks as well, encourage them to join. Really humbled by the number of people joining today and your participation, and we hope that this continues as we meet again on the 20th of March to look at more insights, more lessons on population health. Thank you all and have a good rest of the day.